Good morning. This is Monet Ihanacho with the NEMSIS Technical Assistance Center. Thank you for joining the NEMSIS TAC monthly training. Today is Thursday, December 21st, 2017. Today's webinar is intended for public stakeholders of the EMS community with an emphasis on those who are not familiar with the EMS data. And the discussion is to learn about the challenges and opportunities of splitting the NEMSIS element called eDisposition.12. Others may know it as patient disposition. Today, our presenter is Mr. Rick Cooper. He is current EMS Services Data Manager for New Hampshire Bureau of EMS, and he is also an active paramedic. And we are grateful for his time, and I will now turn the time over to Mr. Cooper.
Okay, thanks, Monet. See if I can get the right screen shared here. Screen sharing is still being recorded. I do this all the time. There we go. So are you seeing the presentation now?
Yes.
Excellent. Okay. Well, we'll get started here. Again, as Monet said, my name is Chip Cooper, Emergency Services Data Manager for the state of New Hampshire Bureau of EMS, and I'm regularly working paramedic using our state system as well. So I'm going to talk a little bit about the suggested changing options for incident patient disposition, also known as eDisposition.12. So we'll just do a reminder for folks coming on that looks like there's a bunch of folks that are listed as just by a caller viewer number. So if you can kind of click on your personal profile there, put in your name so that Monet can keep track of who you are, and also mute your phone either on the website or by on your physical phone headsets. All right, thanks. So let's get started here. As you can see, we're going to talk about just splitting the disposition. This is a work group that started early this summer, actually, and these are the findings that were put together and presented to several national groups as of this fall. So we're going to start by talking about how do we describe an EMS event. So we have some high-level key descriptors that are used by services, billers, all kinds of state data managers, different researchers to categorize and filter these events down for whatever purposes those particular stakeholders are using the data for or using the filters for. And once those are broken down into general categories, they can be evaluated based on clinical criteria and operational data for billing or QA or whatever it is that the agency or stakeholder wants to do with it. So let's take a minute to describe what those key descriptors are. We have the type of service that is requested, and pretty much that breaks down into 911 versus transfers, but there's some other types of requests that are coming in out there that also get used. Then we're interested in the role of the equipment and the equipment's capabilities, and that breaks down in general terms of transport versus non-transport and what was available for equipment, so that we have a general sense of what kind of service could be provided. And finally, we have sort of the main topic for today is the disposition of the incident. And when we break that down, it's broken down into some major points that we want to know. And number one was obviously, was there a patient? If we had a patient, did they get treated? Who treated them? And what level of care did they get? And then, of course, were they transported? And who transported them? And who was in the vehicle when they get transported? And if none of that happened, then actually what else occurred? So some background for the project, as I covered a little bit, in NEMSIS version 2, and currently in NEMSIS version 3.334 and 3.4, eDisposition.12, also known for most of us as incident patient disposition, collects multiple pieces of information in the same field describing several aspects of the event that we just talked about, that I just outlined. So the format and modeling of collecting dispositions, this way, it presents some challenges. So we're asking more than one question to be answered in a single element. And that never really works out well because you got to think pretty hard about all of those areas that you want to know information about and figure out which value in that big list really applies. And we get some pretty long values, and they can be confusing, and they're not very flexible, and we certainly have some holes now that just don't meet the needs of all the EMS delivery models that are out there. So as a consequence, we've had a lot of stakeholders request that eDisposition.12 be split out to address some of these options and make it a little easier for providers to understand what their choices are, and for data managers on all levels from agency on up to NEMSIS to have a lot more aggregation in their data filters when they're analyzing data or looking for particular kinds of calls. So I'm going to just give you a little demonstration here on a test site that I've set up that is open to anybody to go in and try out. And it's completely locked down site, so even though you see some other tabs up here, you can't do anything about it. So just a demonstration of what we currently have. So for describing call, we're going to talk about the type of service requested. Was it a 911 or transport? We'll say it's a 911. What was our primary role of the unit? Ground transport. How many patients do we have? Level of care of this unit here is we're going to pick one of these strange values. And then we have this long list of options that you can see hopefully on the screen of what we have, patient treated, transported, what have you. And really, these are the two fields at the top that we use quite a bit. And so I'm going to drag that out of the way so you can see a better list here. And so here are the values that we currently have. And the color coding is a little bit to show you that these top two values here are the ones that probably get used most by providers. You know, did we treat them, transport them, or did we treat them and give them to somebody else? Unfortunately, there's some real gaps in here based on delivery models that they've been identified. So a common one would be sort of the old emergency 51 Johnny and Roy scenario where they go out in an intercept vehicle and then they always get in a transporting vehicle. And that model occurs quite a bit around the country. And then you have other similar scenarios, and you can see there's nothing that really fits for them. You know, do they put in agency assists or one of these options here? Did they really transfer care, but they didn't, but they're in charge of the care, but they're in another unit? So you can see there's a lot of confusion and limitations because these assists really were kind of intended to be non-treatment type things. And you can also get a sense of looking at our current list that we have a lot of duplication. So we have these 3 assists that are a little confusing and don't quite fit any category in particular. We have 3 different canceleds in here. Again, we're canceled, and then we have, you know, patient information. Then we have 4 dead at scenes. Ultimately, you know, these dead at scenes are either did we treat them and transport them, or do we not treat them and transport them? That's what it boils down to. We can determine dead at scene somewhere else, and we'll demonstrate that a little bit later. And then we've got, let's see, what I think it is, 7 variations of refusal. And the reality is that patient treated, transported by law enforcement, or POV, is a treated, refused transport, quite frankly, because they're refused transport by EMS. And then a couple of standby options here. So lots of duplication with what we have. And then we have some pretty big holes to meet the needs of operations. So you can see some of the challenges that we're facing when we started to look at this project. So the overview of the change plan was, well, ultimately, the reason we're dealing with it right now is because this is a major change to the data set. And so it needs to occur in the release cycle for NEMSIS, and that next release cycle is version 3.5. That's scheduled to really be out with the schedule change late next year, beginning of 2019, based on the schedule right now. So the work groups were created for some significant changes. There's several other areas as well. And this one we'll just be talking about the Disposition 12. So our charge was to evaluate all of our options, the challenges in making changes in the incident patient disposition. And the work group came up with 3 options for the stakeholders to review and look over. So as we go into these, you'll see there's values that we determined. There's a lot of consideration put into these values to try and meet all the scenarios that we know are out there. But ultimately, we're at the point where the final decision needs to be made about which option is going to be used, and then we can work out the final details on those values to make sure that everything's covered. Additionally, all the options will leverage key descriptors that we'll identify specifically in a minute here to better describe the EMS events, because we really haven't used those well, and they help quite a bit in describing an EMS event as part of the disposition too. All right, so 3 options. All right, so here's option 1, and you'll see the trend with the labeling here. Option 1 is to keep eDisposition.12 as a single element and modify the values through deprecations, meaning sort of inactivations, relabeling of existing values, and adding some new values. Option 2 is to split the disposition into a patient disposition and an incident disposition. So now you will have 2 values. And option 3 is splitting into patient, incident, and transport dispositions. Again, all of those will utilize the key value descriptors. So sort of reviewing the goals of these options are being able to describe the call. So what was the category of the call? What was the unit's role when they went out, and what did they have for equipment? Patient contact, was care provided by who and who transported, or other outcomes. So we already covered a little bit this about existing elements. And so the general flow of the incident is we work through, because it's so tied into other things, was that step 1 would be type of service that was requested. This is the major filter that usually occurs for reimbursement, clinical analysis, operation, and what have you. What was the role of the unit? Primarily, were they transport or non-transport? Were there patients on scene, and how many? What was the level of care provided to the patients? And then the disposition, and finally, we'll also talk about the destination types. So a little bit of the table key as we go through here, because we've tried to use consistent coloring. If you see the colors that are in this red color here, those are items that have suggested relabeling of existing values. The orange, light orange here, is new values, and the gray are deprecations. If you're not familiar with that term, that just sort of means inactivation or removal from the data set. So step 1, type of service requested. We found going through that there were several types of service that were infused into both the disposition and some other areas that really didn't belong in those areas. They really belonged here under type of service requested. And we also found some holes. So you can see all the relabeled fields. These were pre-existing, 911 response, intercept, mutual aids. We found some luck, certainly in New Hampshire, I found some good luck by relabeling to the emergency response and identifying primary response versus mutual aid. A lot of providers had difficulty determining that based on their response cards and everything. And since doing that, we've had a lot better compliance and use of the mutual aid field in particular. And there's also been a lot of confusion about interfacility transport versus medical transport. That's real confusing to providers, and they're sometimes used interchangeably and not meaning what they intend to mean. So So those labels were determined to be more clear. Interfacility is clearly a hospital. So we've looked to relabel those, add in values that would cover the scenario of a regular crew with a hospital sending staff. That can affect your billing rates. That can affect your talking about your critical care resources, if you have enough or not. Impact on small hospitals in particular who have to send staff when they maybe only have a few staff on, say in off hours, or identifying calls that have a dedicated critical care or specialty care crew. All of that goes into operational and billing considerations there. And then we were looking for really sort of a catch-all for all that other stuff, the dialysis runs, taking someone home to the doctor's office, what have you, and trying to make that a little bit more clear. And then also we started pulling in, instead of sort of getting rid of the agency assist, those are really about support services. We have cases where crew transport only occurs, especially with air medical transport, getting those crews back and forth between the aircraft and a facility. Mortuary services is interestingly, there was a type of destination for morgue, but nowhere did we define that the type of service would be mortuary services, and we know that happens around the country somewhere. Mobile integrated healthcare is up and coming, and again, there's been no ways to capture that. And administrative operations and rescue actually came out of the primary role of unit. So we've got an expanded list here, but you can see this really defines, what the unit was going out to do, or what were they asked to do, a little bit more clearly. And these were really the elements that we had before, the ones that are in red here, and including standby. And we've expanded that list by bringing some other things in and meeting some new needs. So the primary role of unit. That's always been, this is the existing values on the right-hand side, you can see. And particularly, we have these non-transport fields, which are always pretty confusing in trying to figure out what slot that means. I can tell you that the NEMSIS Data Managers Council was working on extended data definitions, value definitions, and we had a discussion for over 2 hours about the word rescue, because rescue in New Hampshire and New England tends to mean tactical rescue, extrication, ropes rescue, something like that. But if you go down to, say, Virginia, rescue means the first responders. And we just call them first responders. So there's these terms that are pretty hard to define around the country, and they weren't necessarily meeting everyone's needs. So we've looked to change those values over to specifically ground and non-transport or ground and the equipment level there, to cover the capacity of those vehicles, and relabeling this field to units service capability. This will basically be tied to the particular vehicles, because that really doesn't change much from shift to shift. Or if it does, then you'll just simply know that that vehicle was ALS or BLS equipped. And it's also going to allow us to deprecate or at least downgrade a field called level of care of this unit that I'll talk about in a few minutes. So number of patients on scene, this is a field that already exists. We're not proposing any changes here, but as part of the flow for options 1 and 2 particularly, this immediately defines whether you had 1 or more patients on the scene. It doesn't necessarily mean that the patient was treated, just simply that they were there. So level of care provided per protocol. This is a new proposed element, and this, you can see it's pretty simple. It was BLS, ALS, critical care, or community paramedicine provided. This is based on your local protocols, because BLS in between regions can vary widely. In New Hampshire, BLS providers have a pretty robust protocols. They can do blood sugars, they can run a 12 lead, although they can't interpret it. They can probably give a lot more medications than they can in other parts of the country, whereas in other areas, doing a blood sugar is an ALS skill only. So that level of care is determined by the local providers who have a pretty good understanding of their protocols. And this provides some clues for the billing folks to put together with all their other information for billing, for clinical review, for looking at operational deployment of vehicles, and all sorts of things that we've gotten feedback from some very large countrywide agencies and small agencies about the utility of this field. I will make a comment that NEMSIS requires a field for CMS service level. That's the BLS, ALS 1 and 2 field. Those are CMS levels that for CMS are actually well defined, but still can be difficult for providers to fill out. That's something billers are really using, and I have not spoken to a biller yet who said that they would take that information from a provider itself. They still sort that out based on all the information they have to go on. So that field really didn't meet the needs of what we're looking for here in terms of describing an incident. So level of care of this unit is an existing field. We're looking to deprecate it or at least downgrade it to a non-national element. This element really was helpful for NEMSIS sort of as a research data set, but ultimately everyone else collects eCrew 02, which is the crew level. So we know what the crew levels are on the call. And if we add the equipment into the unit service capability, then we know what the equipment is, and we all know what the crew levels are. And we combine that with the new level of care per protocol. We have a pretty good picture of that. This field, I know for my providers, this is pretty confusing to fill this out, and they don't really understand why it's there. And ultimately, it doesn't have any utility for the agencies or even the state level. So we're recommending that this be downgraded or deprecated. So goal of suggested changes. Option 1, we'll talk about that in some detail here. So we're recommending a deprecation of 11 of the 22 current dispositions. And I'm sure based on the slide that we talked about earlier, you can guess what most of those are. And an addition of 7 new dispositions for a total of 18 dispositions. So that's a net change of -4. We're also, as part of that, we're making a recommendation that a zero to many element, in other words, choose all that apply, be added to clarify the refusal release types, as we're taking away generally 7 types of refusals. And even those don't necessarily have all the detail that services may want for medical legal purposes. All right, so this very busy slide here is the combination of existing fields, which are essentially all of these up here that have the code in them. These are all existing fields, and the recommendations to relabel them in the red, to deprecate or discontinue them, or add new values here. Again, this is option 1. Keeping eDisposition.12 is one option. So, and this is the clean list if we take out all the deprecations and make it look at a little less busy. So this would actually be the new option 1 disposition list. And you can see we cover a lot more territory with this. You can say, transported in your particular unit, cared by this unit, cared by another unit. So if you have the intercept crew gets in and they're responsible for care, but you're transporting, a whole range of other things. Transport by another unit to another unit. So this would be, say, EMS unit ambulance transports a patient to an air medical transport vehicle. And so you're taking care of the patient, you are transporting them, and then you're going to transfer care off to that other crew. So we've got a lot more options in there. Okay, and I'm going to go back to our demonstration site and show you what that looks like operationally. So we'll go back to use our Johnny and Roy option here. So they're essentially going out is an intercept in most cases. They're going to be a non-transport something in here, so we'll call them a non-transport rescue. Number of patients is here, and they're going to be ALS paramedic. So this is the existing fields without changes. I'll add in our crew members here. We've got Johnny. I already have the levels in for Johnny, and You got Roy, and I'll add him in. So those guys are already there. We know what their levels are in their primary roles. And then now I've got this list of choices here. Which one do I pick to put their intercept scenario on? I'm not really sure. It wasn't transported by this unit. It wasn't really a transfer of care. So maybe we'll just pick agency assist here. Doesn't quite work, but it's as close as we have. So instead, we're talking about an option 1 with the changes to the key descriptors. So now we have type of service requested. So this is still emergency response intercept. What's the unit's capability? They're a non-transport patient care ALS equipped unit. We have the crew members already there. We know there's a single patient, and the level of care they provide is ALS. All right, and now we have this list here. So we're going to be evaluated transport in another vehicle carried by this unit. So now we actually have a descriptor for what happened for these guys. So we have a lot more flexibility in how we're describing this run. So that's option 1 in sort of a practical sense right there. Again, this will be on the slideshow, but you're all welcome to go to this site right here, www.nhtemsis.org/elite with a capital E, and the username is eDisposition.12, and the password is eDisposition.12, and that is case sensitive for the password. And that's open for anyone that wants to go there. It's just a testing site. So option 2, splitting into 2 elements. If we add in the patient incident disposition, it gives us a lot more flexibility for mixing and matching and better describing what the incident is. So here's our value choices that we've determined for the patient disposition. And there's a lot of discussion about what really falls in the patient disposition, what really falls in the incident disposition. And certainly if this ends up being the choice, I think there's probably some more room about which one goes where, because it was a little hard to figure out what really matched in this element. So, but you can see, we have the evaluated, which makes the assumption that you have a patient. Going back with number of patients on scene, you choose single or multiple. So that on assumption evaluated means that you had a patient there and what occurred with that patient. And some of these are remapped from the existing elements here. Obviously, those would be the ones that are in red, and we have some new values in there too. And then we move on to the incident disposition, and this is really a lot more focused on transport or support services provided, or the overall canceled. So, and side by side, to put these two together, these are the values that we have a choice of. So was there a patient, and was care provided to them or not? And were they transported, not transported, or was support provided to the other crew or not? So going back to our site here again, we're going to look at option 2. All right, we still have our type of service. We can just pick primary response area in this case. In this case, we can say, we're BLS equipped, ground transport, still have a single patient, level of care provided. And now we're going to look and see, okay, what was going on? So we had evaluated primary care transferred to another agency. So that means my agency showed up, we evaluated the patient, provided some primary care, and we transferred that care to another agency. And then in this case, it would be transported in another agency's unit. So that really describes that we did some care, we handed off to the other agency, and that other agency transported that patient. And that's using the patient disposition, incident disposition in option 2. Okay, and then let's talk about option 3 here. Splitting into three elements, the patient, incident, and transport disposition. Again, we actually increase the mix and match options here and can even describe the scene and incident in a lot more detail than we had before. So the new patient disposition, you can see this is very high level. We had a patient contact, they were evaluated and care provided, or something else happened with them, that they were checked out and refused, didn't need care. Otherwise, patient contact support would be something that we have here in New Hampshire a lot is we have a dual response from, say, a fire department and a transporting agency. They either get there at the same time, or maybe the fire department gets there a little later. Fire department's not really there, you know, they're not leading the patient care, but they're there to do support. You know, move the stretcher, move the patient, get bags, you know, whatever it is, sort of scene management kind of stuff. So they're not really doing patient care, but they are supporting the patient contact support, or patient contact care by another agency. And then also I'll mention here that, I know we have here in New Hampshire, and we're starting to hear about it around the country, we have something called Safe Station, where folks that have alcohol or drug dependencies can show up at the station. The local service has pre-established relationships with dependency or mental health agencies. The local EMS agency will do a general exam of the patient, make sure they're okay medically, and then hand them off to the counselors or rehab folks. So that's going on more, and this also would qualify for the baby safe haven kinds of things. So that's there to cover those sorts of scenarios. So the incident disposition it defines primary care, who did the primary care, or whether support services were required. And you notice in this option we have no patient was encountered and the call was canceled. So that defines both the patient and the incident disposition for those kinds of calls. And finally, we have the transport disposition. These are pretty straightforward, easy for providers to figure out which one applies for them, and there actually would be a value for not applicable in the case where it was a canceled call. So here's a comparison, actually a backup one. Here's a comparison of the three together working in concert. Patient disposition, so you have the high level, they had patient contact and something happens. The incident was who provided the care or whatever else they did, and then the transport is pretty clear cut. And then breaking out version 2, option 2 versus option 3, you can see there's a little bit more mixing and matching. Some things that were an incident here ended up in an incident here, but may have also ended up in the patient here. So it was a little bit difficult to sort out which fit in option 2, patient disposition, where it's a little bit more clear in option 3, or at least in my mind. And just operationally, we'll take a look at that again. So here we have option 3. We've got our type of service and unit service capability. We can go with non-transport ALS, whatever it is, and we provided ALS care. So here are the disposition. All right, we had a patient, they were evaluated, and care is provided. Primary care was by another agency, and transport and another agency's unit. So you can see we have lots of mixing and matching. We can really describe an event pretty closely, and the values are fairly short. Providers can figure these out pretty quickly. And pop-up question, is there handout available? I think the NEMSIS folks are going to send this out with a recording, so this slideshow will be available. So these are broken down. You can see sort of the functional flow. And are there more clicks? There's 2 more clicks, yes. But in trying it out myself and showing it to other people, the clicks actually are a little bit easier because the value lists are shorter and they're not as long, and it's pretty easy to go, okay, what happens? And so relatively there's been found to be no impact on those extra clicks, so to speak. And sort of one of the final options here is we found in the process of working all this out that there were some needs for type of destination, better describing the runs, the dialysis or other recurring care centers. So those would sort of be like the cancer treatments, diagnostics for the x-rays or CAT scans or whatever. And then mental health services, obviously, up and coming thing, where a lot of transports for that with the addiction, and you can see none of those were really covered previously. So a summary of suggested changes here, relabeling eResponsible 7 primary role of unit to unit service capability, modifying those elements to be more descriptive and define, easily define transport, non-transport, and ALS, BLS equipment levels. Add an element, eDisposition.12, level of care provided per protocol. That's the BLS, ALS, critical care, community paramedicine. Deprecate eResponse 15, level of care of this unit. Add or modify options for eDisposition.12, which is really the major endpoint. Using eResponse 06, standby purpose, because we're taking away the 2 standbys, which I find confuse people a little bit. And these really have a lot of clarity as to what the various standby options are. That's not an SL element, that's something that can be used locally. For the inter-facilities, especially with the other hospital sending staff for the critical care crews, you can use e-payment 42, specialty care transport providers, and it's a choose all that applies, so you can put all the different kinds of crew members that came on that call, which can have some real value in many levels. Consider adding an element to type of patient refusal and release that would add some value to that, and then add values to eDisposition.21. So I can just swing back here. I didn't cover this. But to deal with the patient dead on scene, we have existing elements right now. We have the cardiac arrest, which is yes, no, and impressions, working diagnosis of obvious death. Those are pretty clear. You know, were they dead? They're either in arrest or they are really dead, and you weren't going to do anything with them. So we don't need to say patient dead on scene in the disposition. And then this would be an example of the refusal types. And then you can choose kind of all that apply here. And this covers sort of law enforcement, and we could even add values into this kind of thing. They didn't think anything was necessary. It's not really an AMA necessarily or protocol, but there's some other options there, and that could be expanded. So just to cover that additional option. So I haven't been watching the comments. I think Monet has, but and again, you can try these out. This is going to be on the slides that NEMSIS will post up. And just thanks to all the work group members that had a part in putting all this information together and doing all these considerations. So, and I'd like to open it up for questions. Or Monet, have you got any other things that were in the chats that I did not see yet?
No, but what we wanted to do was to allow the providers an opportunity to see this information and to voice their opinions on what options they think would work.
Sure.
So we would love to hear that type of feedback today, either on this call, or you can contact myself or Chip and ask further questions or give your opinion about what you think will be the best option. Are there any questions?
This is Ryan Mock with Intermedics. I have a question. Today, many states utilize the eDisposition.12 to drive their rules for required fields. In elements where we're now, particularly like the cardiac arrest, where we're utilizing other fields, how would a state ensure that those fields become required when appropriate?
I think that's kind of a big question. It's all scenario based. Your statement about the cardiac arrests, certainly in my state, I don't particularly rely on that patient dead on scene. I think it's one of several factors that I might use to say that you need to answer that cardiac arrest question. We just simply have in our business rules that needs to be answered, and that is the trigger. ERS 01 is the trigger of addressing the arrest fields. for that particular scenario. There's no question that from the state standpoint or anyone that's sort of managing their own software that we're all going to have to do some work to adjust some of our rules and with any of these other options, no matter which one is chosen. But I know based on some of the initial voting that there has been a lot of support for option 3 in particular. That I think that's been the highest level of support. And my sense, and maybe Clay can clarify this too, I think he's on the call, was that everyone recognizes, vendors and sort of state managers recognize there will be a lot of work in transitioning or sort of modifying all of our business rules. But the overall benefit to the providers and sort of long term certainly outweighs sort of the upfront work that needs to be done to modify some of those rules. So there's always lots of ways to get at directing certain things to be entered in a certain way, and certainly not all of it relies on the eDisposition, but many of them apply to did you have a patient or did you treat them? So it's a little bit easier now to just pick one of those and say, yep, we had a patient, they got treated, or they got transported. So I sort of have fewer choices in a way, or it's a little bit easier to work with. I think it will be having those more specific areas and being able to be more focused.
Yeah, this is Clay. I'll just add a little bit to what Chip said. That's exactly right. What we're hearing as well is there'll clearly be additional work to kind of align the business rules with this change. But I think there were scenarios that just were not well captured with the original eDisposition.12. Thus, I think our providers were seeing some warnings thrown by business rules when they went to check, and they weren't accurate. I think this way, yeah, there will be more work to make sure that those rules meet our needs, but I think the rules will be more accurate with this approach.
Well, I apologize. This is Kim Hartley from Will County 911 in Illinois. I missed the first part of the meeting. What are we looking at? Like, when is this going to be implemented? I mean, what timeline are we talking about?
Clay, you want to handle that?
Sure, happy to. Yeah, so we are beginning our discussions early in regards to what we're going to do with the eDisposition.12. We have really, in regards to our timeline, we have till May to really work of 2018 to really work through this process. This is one of a number of potential revisions we're talking about, but we have till May to finalize this approach. Once we have kind of a final decision on what we want to do with this change as well as many others, and it will go through two kind of beta versions, and really this would not be out on the street for us for actual use, and so I think it's 2021.
Okay. Are we discussing for instance, because I mean, there's already a lot of fields to fill out, and I'm sure that you have been hearing the feedback, and I understand that you're talking, this is certainly more granular than what they're doing now, and NEMSIS 3 was already a big jump from NEMSIS 2, so I'm going to have, chiefs that are going to be complaining about this, so, and want to have a say in this. Are they supposed to be going to their systems? Are we supposed to be going to IDPH? I mean, are they coming to the National NEMSIS site? Because I need to bring this to them and show them that this is what the plan is for 2021.
They're all important.
Yeah, great questions, and so probably most important, Chip has brought up the timeline. This is available on the opening page of the NEMSIS website. If you just go down to the lower part of the website, you can access this and download a PDF that lists the timeline for 3.5. So that may help you. And then you're right. Yeah, how do you provide comments in regards to what's being discussed? That's a great question. So you have a couple of options. One is to provide your written comments to your state EMS data manager. For example, Chip in New Hampshire would be collecting those comments on behalf of providers within his state. And then also you can just provide comments directly to us. If you go to the website there, to the far right where it says staff contact, you could either contact myself or Karin Jacobson or Lisa Young and submit your comments related to these changes. And I can assure you that they would be reviewed. We really have a hard time with comments that just kind of tell us that they don't like something. We can kind of tally the likes and dislikes, but if there are kind of constructive, different type of an approach you would take, or something that would enlighten the larger expert panel about what might be a better solution, those kind of comments are incredibly helpful to us, and we'll be collecting those comments from now through May.
Okay, I'll instruct my users to go through our state EMS coordinator then for that. Thank you.
Oh, great. Yeah, thank you.
And I can also say that as we work through this and have presented this information a number of times, there's been lots of questions that have come up, and sometimes it's simply a matter of like, I'm not quite sure how this is, how would this apply to these different scenarios. And that could be as simple as that. You can put that to Clay or send it to me, and I'm happy to sort of try and answer those questions. I know the presentation seems like there's lots of extra stuff in there, but ultimately we're using many of the fields that already exist. We've done a little bit of expansion on them, but it doesn't become more clicks for those fields. If we went with option 3 on the disposition, it does have 2 more clicks, but I think providers would find it easier to know what their choices are. And a couple of the other recommended elements would be could or could not be used. If somebody doesn't want to use the refusals, if that actually gets added as an element, then that's all good. That's really a field that's more useful to local services than it is for anything else. As a state, I would probably not be looking at that kind of data, but it would be really helpful to a local agency, possibly, or that can be handled by other means as well. A lot of agencies have forms that their lawyers have written up for them, but so really we'd be talking about potentially 3 more clicks. I think when it came down to it, with simpler values to choose. But I understand kind of everyone's concerned about that. I certainly fill out the run forms myself, and at 2 in the morning, I'm not that psyched about how much stuff needs to be filled out either.
Yeah, this is Clay. Maybe one more comment related to that question. I mean, that's a great question, and we struggle here at the NEMSIS TAC. How do we get this information out so that we can actually get comments back? I mean, it's one thing to just indicate that there's a potential change to eDisposition.12. Then, of course, everybody, the hair on the back of their head stands up, immediately. It's a whole different thing to be informed about what kinds of changes we're suggesting. So maybe a really valuable tool would be just to utilize this recording, right? So maybe you can pass this recording around. That'll be posted on the NEMSIS Google group. And Monet, I'm not sure where else you'll post it. I think it'll also be on the website. Is that correct?
Yes. Let me actually have Chip do something for me really quick. Once he finishes his
yeah, sorry about that.
No worries. If you can go to the View Reports tab.
Where View Reports, yep.
Yep, and go to Public Training.
Right here?
Down, yep.
Okay.
Now, if you look here on this page, you can go ahead and just scroll. So we're talking about this particular training or webinar right now. And what I'll do is I'm going to actually get the recording from this call or from this webinar and go down a little bit further on the page, Chip. Continue to go down. And so this training will actually be present here on this page. It'll say previous trainings, but it'll be available so that you can review it for whatever purposes or share it. And so that's where you'll find the information from this webinar.
Great. Thank you, Monet.
Thank you.
Well, if there are any other questions at this time? Feel free to also visit the contact page, and you can send Clay, Karen, or myself, as well as Lisa. You can send the comments or your email information if you want to be involved in other trainings in the future. Thank you so much for taking time out of your day close to this holiday season to join us for this webinar. We appreciate your time. Have a great rest of your day. Thank you, Chip.
You're welcome.
Oh, shit. Never mind.